All right, good afternoon. My name is Jamie Trotter. I am the Associate Director for Patient Advocacy and Engagement with National Patient Advocate Foundation and Patient Advocate Foundation. My panel, Inequitable Access, Outcomes, is going to be joined by Dr. Craig Emmitt Cole, who is a hematologist oncologist with the Carmenos, I hope I'm saying that right, Cancer Institute at McLaren Greater Lansing, along with a patient of Dr. Cole, Mrs. Omie Smith, who is a multiple myeloma survivor and a fierce advocate and educator with the Saginaw Public School District. As a quick reminder, this panel will include a Q&A portion at the conclusion, so I encourage everyone to keep utilizing the chat. My colleague, Katie Donovan, is monitoring your questions and your commentary, and will feed those over to me for a discussion at the conclusion of our talk. So to get us started, Dr. Cole, I would love it if you would introduce yourself and give us a little bit of background about how your introduction to medicine and how you came into practicing in the field of multiple myeloma.
Oh, well, thanks, Jamie, and thanks everyone for having. I've been tuning into the meeting, and this is a super powerful meeting. I am thoroughly impressed and honored to be here today. Um, I'm a malignant hematologist and a myeloma specialist, and how I started in my journey is I thought I was going to be an astronaut until I got to be 6'5" and realized I couldn't fit in a space capsule. And my grandmother and my dad died of colon cancer. My grandfather died of prostate cancer, and my grandmother took care of both of them when they were sick, and so she neglected her health to take care of my dad and my grandfather. And so she was a nurse, and she had metastatic colon cancer. And after she buried my grandfather, she then said, "Now it's time to take care of myself." And she was getting treatment, and I was in college. I thought everything was going, well, when I talked to her over the phone every week. And then she asked me to come down to visit her, to take her to one of her appointments. And so I drove down, took her to her appointment. Her doctor, barged in, did knock, and said, "Vesta, your cancer's worse. We're going to change your chemotherapy on Monday." And started walking out the door. My grandmother said, "Stop. I want to go on hospice." And her doctor turned around and called her every name in the book and just said a bunch of terrible things. And my grandmother just smiled and said, "If you don't put me in hospice, I'll put myself on hospice." And she said, "Well, then," her doctor then just barged out angry, and I'm devastated. And she said, "Take me home, son." And so when I was putting her in the car, she said, "Craig, I think you can do a better job than that lady, and taking care of people." And I learned, and I look back on, and so my whole life trajectory changed. But what I really learned from that is the power of patient empowerment. My grandmother could have easily said, "Okay, yes, doctor, whatever you say, I'll do whatever you say." But she knew what she wanted, and she stood up to her doctor. She questioned her doctor, asked her doctor questions, which is still the mantra that I tell patients, that you need to be empowered enough to say something. And still to that day, that is what is part of what drives me. My job is to not only help my patients, but also to empower them like my grandmother was empowered.
Incredible. I've heard that story before, but I thought the audience should hear it too, because I think it's so powerful. And it leads me to my next question around decisions, because it's sort of teed up how patients have decisions that they have to make along their care journey. And I know that multiple myeloma can be complex with a number of different decision points in their care spectrum. So can you talk about those decision points and the choice that patients have in treatment at the right time for their diagnosis, and how does that sometimes complicate building a trusting relationship between you and your patients?
Yeah, and that's such a good question, because I think that myeloma is kind of interesting because some patients like Ms. Smith have smoldering myeloma and don't need to be treated immediately, and even when it's time to treat, there are a variety of treatments that are available for patients based on kind of their goals of care. And so, it's not like treating an infection with an antibiotic. There's a lot of decisions that need to be made that are by no means unilateral. The first point is, well, if you have smoldering myeloma, should we treat now or not? And that you have to have a rapport with your patient. That you have to have communicated with your patient. You need to communicate with their family. You need to empower your patient and the patient needs to be empowered to really vocalize clearly and think about what their goals are, and you have to accept that. There's another patient we have right now who's smoldering, and we're at the same decision tree, and she is pretty clear in what she wants to do, and I have to respect that. But that respect, is generated by the patient being empowered to tell me what to do. And then when we start treatment, it's not like, again, that you open up a can of beans and put it on the grill. It is, well, again, what's your goal of treatment? And that's a communication. And what is a home life like? And what is your performance status? And to pick the right therapy. I mean, it shouldn't be like trying on shoes where a shoe's too tight, a shoe's too loose, and you find the right shoe. If you have enough rapport and enough communication with your patient, you should be able to get the right shoe on the first try. You should have the right therapy on the first fit. And then the next step is getting a stem cell transplant or not. And I can quote data all day long about the risks and benefits of stem cell transplant. But that takes a lot of trust and takes a lot of communication and a lot of rapport to be able to actually, in many cases, hand off your patient to another provider to do that transplant. And knowing that, you end up being a kind of a matchmaker between the transplanter and the patient. And so there's lots of points along the way where decisions are made to get the right fit for the right patient. And a lot of that requires really good communication, understanding your patient. The most important, tool in practicing medicine is listening, the most important thing. And that I have the idea of what I want to do, but I have to ultimately respect what the patient wants to do, which is really in the same way that my grandmother had made her wishes known, way back when.
Absolutely. I want to bring Ms. Smith into the conversation. Speaking about trust and respect, Ms. Smith, as a patient of Dr. Cole, you talked in conversation with me so passionately about the bidirectional trust you've been able to establish between your providers along your treatment journey. Can you share more about that experience and how you were able to establish that trust and why it's been so pivotal in your treatment journey?
I will. Good afternoon, everyone, and thank you for having me as a patient advocate. This has been my dream. So to have it to become reality is so nervous, but satisfying for me. So thank you, Dr. Cole, for the recommendation. And thank you again for having me. Dr. Cole is correct. My journey started almost 10 years ago with Dr. Cole, and he was at U of M at the time, University of Michigan Cancer Center. And at that time, I was getting a second opinion. And, you hear the C word that you may have at that time. And I had no symptoms at that time. As he said, I didn't have symptoms. So when your general practitioner tells you to redo some blood work, the first thing you ask is why. You know, that scare and fear comes into you, and they tell you not to worry, but of course you do. And I had to redo the blood work, and they told me it was a potential that I need to see an oncologist. And that's when the radar went up, and you're going, oh my God, you know, I do have a history of some cancer in the family. My mother had colon cancer, but she did not die from that. My sister has had 2 brain surgeries, but no one in the family have ever heard of multiple myeloma. So that's not one of the cancers you think of right away. So I eventually had to go to an oncologist here in Saginaw, and she did do a bone marrow biopsy. After the bone marrow biopsy, she said she wasn't alarmed, but she was concerned. So I did ask her for a second opinion. She had not met Dr. Cole at that time, but she had heard about him. And she asked me would I like to go to U of M. That's an hour and a half away. I said, sure, I'll go. And I prayed about it, and my husband and I went. I did go and visit one. I was impressed. He listened to me. A lot of patients, I've talked to so many multiple myeloma patients that are very unhappy with their providers, and I've asked them to please consider getting a second opinion. And I have sent several patients to Dr. Cole, and they've all been very, very, very pleased. You want an oncologist, hematologist that first of all is educated. And Dr. Cole is very educated. I checked his credentials before I went. He would tell you I research everything. So I did check his credentials. My husband and I was really impressed when we met him. He didn't rush me. He wasn't one of those 15-minute doctors, as someone mentioned earlier in Mississippi. She's exactly right. We as patients do not want a doctor that's rushing us. We feel that they don't care. And I've had that happen before in other areas. We feel that they don't care. They don't have time for us. They're just trying to get the insurance money and move on. But Dr. Cole, I felt like I'm keeping other patients. I'm spending other patients' time when you're with Dr. Cole because he doesn't rush you. And I like the fact that he listened to me. That was number one for me, because a lot of times when you don't have the symptoms that some of the other patients that are talking to you have, the back pain and all the other pains that I was thinking I should be having, then you wonder if your mind is playing games on you. Are you really sick? You know, is it really in the blood work? So I always ask to see my blood work. So as someone said earlier, one of the doctors from Mississippi said earlier, you have to be your own advocate. And that's what I tried to do. He showed lots of empathy. And as I said, he had the experience. He's a renowned guru, as we all know, and he travels and speaks. My confirmation was when my doctor here, Dr. Lou, was at a conference, and she came back to me that next week at one of my visits, and she said, guess who I met? And she met Dr. Cole, and she was so impressed. And from that day forward, she and Dr. Cole stay in touch about every appointment that I have, whether it's with him or with her. They give each other their my blood work. They converse whether or not, what's the next step for me. And now that I've been through my stem cell transplant in Detroit at Carmanis, they also stay in touch with Dr. Cole. And I didn't think it was a coincidence that Dr. Cole was a fellow with the team that I had in Carmanis in Detroit. I almost went to Anderson in Houston because my sister was there, but the Lord just kept telling me stay with Dr. Cole and his team, and I'm so glad that I did. I think some patients are introverts and they're afraid. There's that fear that all doctors know what they're talking about, just do it. But no, you have to have a great relationship with your doctor. You have to have confidence in your doctor because this is your body. This is not your doctor's body. Male, female, black, white, green, or yellow, it does not matter. This is your body. And I think we have that innate ability to have discernment. God gives us discernment. And when you feel something's not right in your gut, I just feel you need to get another opinion. Or if you don't think you have what they're diagnosing, please look at your blood work. We have the right to ask for all images, all blood work, anything that pertains to our medical history. And I don't think every patient knows that. So I think we need to do a better job, not only the patients, but the families and the doctors, of letting patients know what their rights are.
Mhm.
Thank you, Ms. Smith. A lot of what you said, I was smiling through because I think you sort of embody a lot of what Dr. Cole has been, and some of the themes that the other panelists have shared around trust and active listening. In our NPAF has an advocacy curriculum that talks about in one of the storytelling modules around being a professional patient. And I think you're the embodiment of that. So thank you so much for all that you do for yourself and on behalf of just the spectrum of multiple myeloma and being an advocate and educator for other patients. So Dr. Cole, I want to turn it back to you. If you could take a moment and explain how multiple myeloma represents the enormous progress that's been made in treating certain cancers, while at the same time serves as an example for barriers and inequities many patients face in benefiting from some of this progress.
Yeah, that's I'll say this over and over again. That's such a good statement and such a good question because, back when I had hair, way back in the past, when we were giving chemotherapy to multiple myeloma and giving chemotherapy to everybody, you could basically go anywhere and get the same kind of drugs, no matter where you were in the country. Cytoxan or cyclophosphamide was everywhere, and it was cheap, and everyone had access to it. And as myeloma therapies and really as cancer therapies have become more sophisticated, as you go into some of the newer drugs that are T cell oriented, and you go to the newer drugs that are monoclonal antibodies, and you go, and the progress has been just breathtaking. But how we've gone from, survivals in multiple myeloma that were 2 to 3 years to really uncharted territory. We don't know how long people live with myeloma these days because the progress has been so rapid, and it has been an incredible and satisfying journey to be part of that. However, the cost of those drugs has also skyrocketed. As the technology has gotten better, the cost has gotten higher. And now we're starting to see how, one of the big risk factors. So, what are the main things that determine survival in myeloma? And I am certain in other cancers. Yes, is stage. Yes, is, response to therapy. But, your social economics, being poor with myeloma will kill you. It will shorten your survival if you don't have resources or your clinic doesn't have the resources to get the newest medications. When you look at the NCCN guidelines of how to treat multiple myeloma, those are multi-million-dollar therapies over the course of someone's lifetime. I mean, they are very, very expensive. And it is, I think, ignorant of us to say that everyone has access to those medications. So, being poor will shorten your survival with this disease. Having access to medical centers. One of the things that drives me bananas about survival in myeloma is that it's linked to myeloma specialists. That if you're treated at a myeloma clinic, that your survival is longer than if you're not. That makes no sense at all. That makes no sense. That means that myeloma physicians have not taught community providers and how to treat this disease adequately, and that those clinics don't have the resources to get these medications to the patients. Sure, it shouldn't matter if you see a myeloma specialist or if you see, the same oncologist that your grandmother and father had. You should be able to receive the same amount of care in a reasonable cost. And the third thing is access to clinical trials. That again, we have centralized clinical trials around big academic centers, which has left huge deserts in this country, huge deserts throughout the Southeast, huge deserts in the West, actually huge deserts in almost every state in the Union, where there is no access to clinical trials, no access to the best therapies. So we always applaud and say how great we're doing in myeloma, and we're doing fantastic in treating myeloma, but it's only a few patients. And I have said, my colleagues are saying, well, we're going to cure myeloma. And I come back at them and say, you're not going to cure anyone till you have cured everyone. That cure has to be accessible to everyone, to the little grandmother that lives in the thumb of Michigan, to the little old guy that lives in South Central LA. We have to cure everyone.
Thank you.
That was kind of a long answer to a very good question.
It was perfect. Thank you. And I want to come back to something you said, but I want to bring Ms. Smith back up. Ms. Smith, could you discuss your ability to advocate for yourself in seeking a second opinion, and in what ways that may or may not have been a difficult decision for you? You highlighted some of that in your previous response, but I want to dig a little deeper into that.
Yes, I would say that it wasn't a difficult decision, but in that U of M and Dr. Cole was actually, it's about an hour and a half, hour, 40 minutes, depending on traffic. And that was, I think that was a hesitation at first, the travel. And as Dr. Cole said earlier, not everyone has that choice. Not everyone has transportation. Not everyone has the financial means to, and I mean, you know, you're paying for gas, you're paying for food, and parking sometimes. I mean, it's a great decision because you're toying with, do I look outside of here, or do I just stay here and accept the provider that I have? But I'm always a person that's researching. So yes, I wanted another opinion so that I would know for myself if this bone scan is telling me, okay, you may need to be treated. May was the word that I kept hearing, or we can wait. I don't want to wait and something's manifesting in my body. So yes, it wasn't a hard decision for me. It was something that I felt that I needed to do for my peace of mind. So yes, I did do that. And I think the harder decision came later when Dr. Cole diagnosed with me with the smoldering myeloma. And to me, that was like something's just laying dormant for me, and that it may or may not develop to become cancer later. And I remember it has always stuck with me that Dr. Cole said, well, you'll probably be out of the woods in about 5 years, because my numbers would fluctuate. 1 month, I'm doing fine. And the next month, it's moving up again. And it just kept fluctuating. So after that 5th year, I thought I would be out of the woods. But every time I got close to the 5th year, it would spike again. Something would go crazy. So that's where I was. As he said, it was a choice of, okay, Dr. Cole, do I get treated or not treated? And do I get treated here with him? Or do I go back home where I won't have to have my family travel? And that was basically the dilemma for me, because I was seeing Dr. Cole once a month. And then I would beg him every time I go, can I go 3 months? Can I go 5 months, 6 months? And he's like, no, not yet. If you look at this number, and Dr. Cole always drew me, I still have everything. He drew me pictures that I share with patients now. And they're like, can you send us that? And I was scared. I'm on several Facebook support groups, and they were like, can you send us that? And I do. I share, because I love that he, like he said, he takes the time with me. So once I realized I was comfortable with him, then it wasn't that big of a choice or a dilemma. I knew within myself that I had done the right thing. So I know patients have to not always listen to others, because I've had people to ask me, why do you go all the way to Lansing? Why did you go all the way to U of M? We have doctors here, but you have to be, and not that I'm not comfortable with Dr. Lou, because as of right now, I'm still on maintenance therapy, in that I'm in remission for almost not quite a year yet. I've been in remission, but I do see her 2 months here for treatment. And then I go to Dr. Cole like next month. So he's allowing me to have treatment here twice a month. I mean, 2 months here, and then I see him the 3rd month. And I'm praying that when I see him next month, that my numbers are well, and I have my treatment there, and hopefully I can get on every other month. But you have to do as a patient what you feel is best for you and your body, and not listen to everyone else. Because as I said, when you have that trust in someone, then in a doctor, and that's not always good, easy to find. I was blessed that I have insurance. At that time, I had two insurances, my husband and myself. But at this time, I only have one. And yes, I've had to fight several bills. Dr. Cole helped me fight one for almost 2 years. And we don't know why they wouldn't approve it. They approved it years ago for one of my biopsies, but the next one, bone marrow biopsies, then the next one they wouldn't approve like a year and a half later. No reason. It was a code, and they finally paid it. So I wasn't going to pay it because I knew that I did not owe it. So we just have to, and I had a great advocate for me at Carmonis as well in the financial office. So we have to tap into those resources, as Dr. Cole said earlier, or maybe you, Jamie, but sometimes patients don't know the resources are there. And as he said, those medications, the medications that I'm still on, I looked these up this morning. I'm taking Zometa injections once a month, $973 without insurance. Acyclovir, it's only like $49. That's one of the inexpensive ones. Revlimid, it can be up to $24,576. That's unrealistic. The cost was $16,000 in 2020. It was $4,515 in 2005. So I'm in the wrong profession as a teacher. Someone's getting filthy rich. The Dodara that I get an injection for, $758 for 5 millimeters. And then I take low dose aspirin each day. So when people hear that you're in remission, they just assume, oh, she's free of cancer. There's nothing else she can do. No, we're still on maintenance for the rest of our lives. So when I retire, I'm not sure how that's going to affect my insurance. But these medications, the vitamin E that we take for our hormones, for hot flashes, there are side effects that we're dealing with. Linesse for either diarrhea or constipation. Cymbalta, dealing with the nerve pain. I feel it now. The nerve pain that you have from neuropathy. Pain pills that you take every now and then because you really don't need to take this pill because you're on this medication. You have to remember all that and be educated. I had a friend to ask me, how do you know all this? Because I've been doing it for so long, almost 10 years with Dr. Cole, and then now almost 3 years dealing with this journey, that you have to know, you have to do what's best for your body. One of the doctors mentioned earlier, diet. That is a key factor. I was doing the Mediterranean diet, and Dr. Cole said he thinks that's what helped me for so long to be pushed out from it really coming into play in my life later, because I was on the Mediterranean diet. So I think a lot of times, as another doctor said earlier, it's expensive right now to eat healthy. It really is. So we have to be creative, and we have to tap into our friends and our family. But there are programs out there. I had a program that I'm on now. I did not know existed. I was paying copay for my Revlimid, which is 21 days on and 7 days off, very expensive. And I had one of them tell me that, there's a prescription program you can get on. No, I did not. So there are options out there. We just have to be advocates for each other.
Thank you, Ms. Smith. This next question, my wheels are spinning. So this next question is going to go to Dr. Cole, but I'm willing to bet you have a response as well. So I want you to respond or react to this question as well, Ms. Smith. So Dr. Cole, there's been a lot of themes that we've talked about: trust, active listening, and truly resources and access in order to pay for or be able to afford a lot of these treatments. In the last panel with Ms. Freddie White Johnson, she mentioned that there is a historical lack of trust in the system, and it's rooted in history, but it's showing up in present day situations that are arising within the health system down in Mississippi. So I want to figure out, so what do we tell the Black patient in Mississippi that is living in a rural community with no access to care, limited resources? What gives them hope? How do we reach them, and how do we make sure that they too have options when diagnosed with multiple myeloma. You've talked about CAR T therapy and how these therapies are available that show positive outcomes, but are extremely expensive. So how can we touch those patients and reach them and make sure that they aren't just left out of options?
Yeah, but that's a question. I mean, that is a very good question, and I think that is, the mission, that, the dual mission of being a cancer researcher is, finding better ways to treat cancer and finding better ways to get the cancer treatment out into the community, into places that we're not reaching. And I would say one thing is that, and one point of hope is to tell people that are in, like you said, in the Mississippi Delta area, that we see you, that you're not invisible to us. That I am on several committees and meet several times. In fact, we're going to meet in a few weeks down at Hermanos about how can we get out to these places that I will admit has previously been ignored. And so I think one point of hope is that we're trying to reach you, and that we see you. The other thing is that, the option of telehealth. And so, COVID was awful, but one thing that COVID did give us, the COVID times gave us, was telehealth, and being able to reach out to places. So I have patients that I do telehealth in very remote communities, in Michigan, and communities that are in Hawaii, and people that are in the South that I do telehealths with, and that I work with their doctors and send their doctors notes. And it's the same way that I talk to Ms. Smith's doctor in Saginaw. I communicate to these doctors in Honolulu, communicate to these doctors in the South, about treating myeloma. So you don't have to live next to a myeloma center to get good myeloma care, because telehealth can reach out to you. Of course, that means that you have access to the internet, which is, an issue in and of itself. But there is a way to reach us. And of course, that takes a bit of empowerment to ask your doctor, how can I need a second opinion from somebody? Who in the state can I talk to about my disease? And get on that list and be persistent about that list to be seen and to be recognized and to be heard. And just like Ms. Smith, she spoke so much gospel today, it's like ridiculous. But one thing that she said is being empowered to recognize that if something isn't working for you with your doctor, you move on, that you get a second opinion, and that you don't settle. And if your doctor's not listening to you and you don't feel like you're seen and heard, move on. And that's what I did with my doctor. My first doctor, we just weren't clicking. And so nothing against him, but I needed somebody else. And I think the third thing when you talk about, clinical trials and CAR T and what can we do, I think some of what we need to do is to change some policies, in some of the states that we live in. CAR T is an incredible therapy, for multiple myeloma, and to get T cells to kill cancer cells has been revolutionary, and we've never seen responses like we see with CAR T, and with the use of transplant. But there are 10 states in this country that don't cover transplant for myelodysplastic syndromes and sickle cell. There are 7 states that have restrictions, Medicare restrictions and Medicaid restrictions on who can get transplanted or who can get transplanted and get CAR T therapy. And where they say that if you're restrictions such as obesity, disabilities, mental health issues, that you can be denied getting a transplant or getting CAR T based on mental health issues when you have cancer and you're depressed. And those are issues. Those are issues that we need, to make policy on and to press the people who make decisions and regarding insurance in our country to get rid of some of these restrictions. There was a study that was done in Louisiana where 33% of eligible people for CAR T couldn't get CAR T because of insurance costs and relocation of care, resulting in a 60% mortality in those people that couldn't get access to CAR T. People died because they didn't get access to these drugs. And that is a policy change to remove. Obesity should not be something that prevents you from getting good care. And there are policies that do that. And that's what we need to change. And finally, for clinical trials, the ownership and the blame has been put on patients long enough. There are several studies that show that Black, Hispanic, and Asian patients are more likely to be wanting to be enrolled in a clinical trial than whites. However, when you look at myeloma, 80% of patients enrolled in clinical trials in myeloma are white and 4% are Black. And that's because providers aren't, the researchers aren't offering clinical trials. And we need to, and that is what we need to work on. And that's what I tell my colleagues, is that everybody needs to be offered clinical trials, because you don't know how well these drugs work until you have tested them and you found the benefit for everyone. I hope that answered your question.
Very much so. Very much so. Mrs. Smith, I don't know if you have a reaction or response to that.
Well, he said everything, but but I do want to say that I guess when you asked the question, Jamie, the first question that came to my mind is, who really cares about those people? Who really cares about those patients? Because I'm from Louisiana, since he mentioned Louisiana, and my daughter, our daughter, attended Jackson State University, so I'm familiar with some of the Delta area. I guess my visualization as I'm sitting here listening to Dr. Cole and thinking about what I heard previously before this with the other doctors is that we have to care more about those patients. And when I say we, I'm talking about the whole world, the whole United States, not just the state. But I think a lot of it starts with our politicians. We have to fight for better laws, because as Dr. Cole is stating, it seems like it's varying from state to state. So I thank God that I'm in Michigan, where I didn't have to fight to get the stem cell transplant that I needed. I do know a friend that had it in Louisiana, and she did tell me she had some glitches and that she finally got it worked out, but it was a fight. And as Dr. Cole said, just because you're obese, depressed, I wasn't depressed before the stem cell transplant. I did have bad days and good days. I'm not going to sit here and say it's all glory. It is not. You have to be a very strong-willed and strong-minded person. Ironically, this is Mental Health Month, and we need to stress that. And some people don't like to talk about it. And some people will not talk about them being depressed or feeling that, I have a back pain. It might just be arthritis. No, we have to make sure those people get those annual checkups. But it says, Dr. Cole, and you were saying earlier that when they're out in the rural areas, then we have to check on our own. We have to make sure that they're getting an annual checkup. I had to fuss at one of my brothers to make sure he was getting a checkup. It wasn't really, that's not really a checkup. He was just getting a checkup on his job. No, you need to go to your doctor, your practitioner, to get a full blood work checkup, annual checkup. Let him touch everything you got and check you out. And that's hard for some men, I've noticed. But those annual checkups make a difference. And if they're not doing blood work, I tell my friends, find a doctor that will, because that's how I found mine. If it wasn't for the blood work, I don't know where I would be today. But we do need, I think, to get those laws changed. We have to fight at the higher level to make sure that those laws are changed, not just for the states we live in, for all states, because as he said, it's rising in African Americans, and we don't know why. We're researching. We don't know why. So we have to be advocates for those people and go out and reach them. And some of them are scared. They don't want to know what they have. I've had some people say that, I want to know. But we have to, especially if they're elderly and they're uneducated at times. And we have to earn their trust, first of all. And then we have to get out there and make sure they have transportation, make sure they know what programs are there for them. They think because they don't have insurance, they're just going to sit there in pain and suffer and die. No, you have rights. There are programs for you. We need to take the programs to them And as Dr. Cole said, some of them may not have the technology for telehealth. Okay, we need to get them technology.
Mm-hmm.
We need to find grants for computers and laptops. We do it at churches and schools. Why can't we do it for them? I just think that we have to do more. When I say we, that means us on here today as well. We have to do our part. There are rural areas in Michigan. We need to reach out to those. You know, when was the last time you had your checkup? I just think we have to be more than just on here today as a Zoom, but we do have to reach out to those areas, because I'm sitting here thinking, how many people are we missing? How many people are we letting die because they feel they don't have anyone that care about them? They don't have an advocate, or they don't have the means to go to the doctor as we do and get it paid for. So I just think we need to do better in that area. And in the technology, I know is a big piece, and training them on that technology. A lot of them are afraid of it because they're not familiar with it. And I just think that we need to do wellness checks if we haven't heard from someone in a while, or they've been feeling bad, or as he said, depression or pain or whatever the case may be. We just need to do more wellness check and just care about our fellow mankind, no matter where they are.
Yes, yes. I love that. I'm going to take that, if it's okay, I'm going to steal that and say, check in on your own, because that is absolutely what we need to do. Because you can get lulled into a false insecurity. If I go through my clinic and I just put my blinders on, I can get caught in this idea that it's all okay, and it's not all okay. And we need to check in on our own. When I go to this meeting, when we're talking about checking in on rural African-American communities, that's what I'm going to say.
Thank you. Thank you both. And we just have a couple of more minutes left, and I want to turn over to some Q&A from the audience, and remind the audience, if you do have questions, now's your opportunity to drop those in the chat, and hopefully we'll get to them and be able to answer. There was one that came in around incorporating nutritious meals for people who can't afford it or don't have access to food. I know, Mrs. Smith, you talked about the Mediterranean diet being such a vital regiment in your treatment progression. And I don't know about Dr. Cole, if in your practice you guys have case managers or advocates or social workers that can maybe speak to some of these food insecurities that patients may be facing, that you're able to counsel them on.
Yeah, we're right at, in Lansing. So I have two practices, one in Detroit and one in Lansing. And Lansing really is at an interface between, urban and Lansing, and it drops off very rural very quickly. And so we do, our social worker here and our support system here, we do have a food bank that we, continue to keep going for patients, because these treatments are so expensive. And we do have relationships with some of the restaurants around here to try and help us out with that, because, it is, and it can be a huge problem. And one thing that we talk about is, the expense of processed foods versus the expense of fresh fruits and vegetables. And there it is. I mean, it is expensive to do, and frequently inconvenient. But I think some of it is education, and telling people, to be empowered to walk away from some of these things and walk towards others, and to be comfortable asking for help from like our food bank.
Mm-hmm. Thank you.
And Jamie, I think too, we forget that it's healthier to eat at home. I think during the pandemic, a lot of us are eating more at home, but some are venturing out more now to restaurants, and it's okay, but we don't eat out a lot. And I think a lot of that came from me when I came home from my stem cell transplant, I couldn't be around people for months because the first 100 days are critical. So we ate at home a lot, as we did with the pandemic. And I know it's expensive, as Dr. Cole said, but once you weigh your options, if you sit down and make your meal plan versus going out to eat, you will find it's actually cheaper. And a lot of Mediterranean diet is fruits, vegetables, sometimes fish, and you can cook those in various ways, whether it's baking, frying, whatever, you can do that. But I think that we just have to be more diligent of reading the labels. as he mentioned, processed foods. They're not good for us. We know that. Chips and cookies and all that. If you read the ingredients, a lot of those, and start Googling what they are, a lot of those are dyes that we're putting in our system. And it's not just our diet, but what we wash our clothes in, what we spray on our bodies. All of that, I think, plays a part into what we put into the environment and what, at the end of the day, we're doing to our system, we're doing to our bodies. I just think we just need to more. Now, I'm trying to do better. My children have been fussing at me about doing more exercise. So I'm trying to do better about that, because I know I really need to do that too, not only for my physical health, but my mental health. So I'm also working on my mental health. I think when you do better and you feel better, it combats depression. It combats everybody around you is happier, I would say. So I think we just need to be more diligent of, okay, how can I make a better meal? Do I do spaghetti? So the last 2 days, just be, especially if you have children, just be more diligent of that and what I can do better. And I get online and I Google recipes, Mediterranean diet recipes, or if I have a taste for fish, okay, Google some fish recipes. And I found that helps a lot as well.
Excellent. I think we have time for one more question before moving on to our next panel. Dr. Cole, someone in the audience says, I know you touched on this, but would you be able to delve more into the diverse health goals that different patients may have? I think this can be beneficial to better understand specifically how the provider should respond and what types of questions to ask.
That's an awesome question. So a trick is when you think about it, people have cancer and they come to you, or they have any medical condition, and all of us are biracial. What I mean by that is that there is the main race and the main European kind of race that that the medical establishment is built around, and then there's the race that you have when you're at home. When I'm at home, I'm an African American guy. When I go into the clinic, it is very European. And what we need to, and so when patients, when they walk in the door, they have to leave their true selves behind and adapt to it, adapt to this European system. What we need to do is meet our patients halfway. We need to know what culture do they come from? Where do they come from? Understand that and meet them, not force them, shoehorn them into a European cultural construct, but meet them where they come from. Then the communication is way, way better.
Fantastic. I think that's we're out of time, but I think that's a great place to stop and a great point to leave the audience with. So thank you so much. I could talk to the both of you for much longer, but we do have to move on to our next segment. So I cannot thank you enough. And I will certainly be following up with you, Mrs. Smith, and you're now a friend of NPAF. And so I thank you for all that you do. And thank you, Dr. Cole, for being such a fierce doctor, provider, friend, advocate for the community of multiple myeloma.
Oh, thank you so much. And thanks for everything.
Thank you for having me. Thank you so much.
Thank you. And so now I'm going to introduce our next panel. Last year, we had the opportunity to meet some physicians from the University of California, Los Angeles Medical Center when working on our shared decision-making project. During this next panel discussion, you will hear my colleague, Ashley Freeman, chat with those doctors about the inequities they see within medicine and the actions they are taking to be change agents within the system.